Hi everyone, so we're gonna start over. So it's my privilege, my honor to introduce Frank Gijsen, who's the next speaker. So Frank started, he's a mechanical engineer by training, and he started by working during his PhD on the blood flows in large vessels at a time where it was not so common as a mechanical engineer to do such things. And so his first papers combined experimental and numerical approaches to study non-Newtonian effects in large arteries. And it was fun to meet him now because it's I think it's one of the first papers, few of the first papers that you start with when you start working on large arteries, blood flows, etc. So really classical papers now. And from this initial contribution in fluid mechanics, he developed now an original range of methods, so with fluid mechanics, solid mechanics, imaging also, especially in the context of atherosclerosis, to study the effect of blood flow, wall shear stress on plaque rupture, composition, etc. And so more recently, he got interested in more neurology applications to apply all those techniques to study thrombus with kind of the same questions like composition, mechanical modeling, etc. So he's currently a professor in an associate professor in two departments, so biomechanical engineering at TUDelft, and also in the department of cardiology at Erasmus Medical Center in Rotterdam. So we are very proud to have him here, and leave the floor to Frank. Thanks.
Thank you. Well, thank you for these very kind words. But as soon as your papers are going to be called classical, that means you're very old. I guess. Don't not so bigly there in the last row. Okay, today I'm going to talk about thrombus mechanics. And I think I would like to first start, of course, the organizers for inviting me, but also generating such a broad perspective on thrombus in general, and I hope I can add to that flavor. And I'm going to talk about thrombus mechanics. I will talk about microstructure, mechanical testing, imaging, and device design. So if we talk about intracranial thrombi, of course, the process of thrombectomy is really very important. That's the preferred way of treating this disease, by removing these thrombi from the vessel as quickly as possible. And that procedure has evolved over the last decade quite a bit. And this animation shows you.
This is an animated video of a thrombectomy. So we place a large catheter in the carotid artery within the neck, and through that we advance a small micro wire that goes up through the blood vessels. It comes up to the point of the occlusion where the clot is, and it passes through the occlusion point into the normal vessel beyond it. Over the tiny wire we advance a very small catheter. It passes through the blood clot, and then we take the wire out. So we usually inject a little bit of contrast beyond the tip of the catheter to ensure that we're still in a blood vessel, because remember, we can't quite see this on an angiogram. And then we advance the stent retriever, and just by pulling back the catheter, the stent widens and deploys itself in the blood vessel. It engages with the clot and allows some immediate restoration of blood supply. Sometimes we inflate a balloon in the neck to stop blood flowing and washing the clot off, but we pull back the stent, which has now engaged the clot, and it pulls and comes back into the catheter in the neck, and then we remove it altogether from the body. And if at first the clot doesn't come out fully, then we go in again with further path.
I'm showing you this video mainly not only to illustrate the procedure, but also to point out the wording that this surgeon uses. He talks about passing through with the microcatheter. He talks about engaging the stent retriever with the thrombus. Well, from a mechanical perspective, these are all very violent procedures. You have to break it, you have to rupture it, and the thrombus actually is completely demolished during that procedure. And that's one of the reasons probably that of the procedures that we have, they are pretty successful, but a significant number of these procedures still fail to remove the thrombus efficiently. So if we look at that video back again and keep that in mind, this cartoon basically represents more or less the mechanical loading conditions that thrombus is exposed to during the procedure. There is hemodynamic stress working on the thrombus. There's a vacuum forces working on the thrombus if we use aspiration, which was not used in the previous one. There are tensions working on the thrombus while trying to pull it backwards. And of course, there's interaction with the wall during the interaction with the device. And all of these lead to a very complex mechanical loading conditions of that thrombus during the procedure. And even this cartoon is pretty kind because failure of the thrombus is not included in this cartoon. So knowing these mechanical properties is really very important if you want to do improved diagnostics, if you want to improve therapy, if you want to make good designs of devices to remove this kind of structures, then we have to know about the mechanical properties of these thrombi. And we heard a lot about these thrombi, of course, these intracranial thrombi. And there are lots of cells and substances playing a role in how these thrombi behave. From a mechanical point of view, 3 are of eminent importance, and that will not surprise you. It's the thrombus from a mechanical perspective. It's a fibrin network that encompasses a certain amount of red blood cells. And in that network, there are also platelets that make sure that these thrombi contract in a more or less state. So these 3 components will come back in my presentation very frequently. What I'm going to talk about, first, of course, we know that for these structures in general, there's a very strong connection between the microstructure and the mechanical properties. So we have to know how these thrombi look. That's what I'm going to talk about first. Getting patient data, of course, is very difficult. So we would like to make analogs so that we can do much testing in the lab. We're going to talk about that in the second part. Measuring mechanical properties of soft biological tissue is a challenge in itself. Of course, in the end, we would want to be able to image the structure, and through imaging the structure, image the mechanical properties of these thrombi. And a final part, I want to say something about removing thrombi effectively with a new device design. So how do they look? What we actually did in a pretty large clinical trial, including 70 patients, we collected all the thrombi from the patients in the operating theater. And you see here several vials, and that's because there are several passes, several attempts to remove the thrombi from the artery, and they are all collected in different vials here. Then we've got a device made here, a custom-made device, a very simple one, to cut them in 2mm pieces, which we then photograph separately, and then in the end we can chop up a part of a thrombus of a patient into several pieces to do the histology of each of these segments separately. So we get cross-sectional information, we get information how this composition varies over the thrombus and also within a patient. So what do? Staining-wise, we've seen quite a lot of histology. We do the standard histology that we do is H&E, the MSB, and the CD42. Especially the MSB is a very important one because it provides quite a lot of contrast, and the CD42 we add because we want to have a separate staining for platelets. So what do we get from these stainings? Again, an example. For the MSB, for instance, because I'm going to use that most frequently here, the yellow parts are the red blood cells. You can see some nucleated cells that are white blood cells. The pinkish stuff is fibrin and platelets. And by combining these 2, we can make a separation between the fibrin and the platelet content in a single cross-section. What I already want to point out here is, of course, it probably does not surprise you very much, but that these thrombi are very heterogeneous. In this case, and that's something that we see roughly in like 1/3 of the cases, you can see that there is like a halo of fibrin and platelets at the perimeter of the cross-section, while the central part is more dominated by the presence of red blood cells. And this is confirmed by the platelet staining here. Overall, they're very heterogeneous. And like I said, this is a pattern that we see in roughly 1/3, and many other patterns are present there as well. One specific problem that we encountered while trying to analyze these data is, by tradition, histology, of course, is more of a qualitative science than a quantitative science. So doing an accurate quantification in an histology image is quite difficult, especially, well, till pretty recently, the only way to do that accurately is by doing manual segmentation of all of the components, which is a lot of work. But we recently stumbled, and that's why I'm putting out this slide, because I want to share that with you, a program called Orbit. It's freely accessible, which allows you to first generate an exclusion model, which basically tells the program, I don't want to analyze these parts of the image. And then you can make a classification model where you train the model on, like, say, roughly 6 to 10 images, and then it can pretty accurately and pretty consistently do a pretty good segmentation. So, like in this case where we have 700 of these cross-sections, this is truly a very good help. And this is the outcome of that patient study. So let me guide you through this image. Each bar here represents one histological cross-section. The blue part is, so if we go here on the left side, then the blue part represents the amount of red blood cells in that cross-section. The brown part, the part containing the fibrin and the platelets, and the yellow part, the white blood cells. So these are 635 cross-sections, and what you see is a super even distribution, which means that if you get an histology sample of a patient, you basically can get anything. You can get a thrombus or a cross-section with almost exclusively red blood cells, and you can find quite a lot of them with no red blood cells at all. On top of that, there is quite some variation in the amount of white blood cells. We didn't do any categorization according to that. I mean, it's something that other people have been avoiding as well, the immuno part of it all. In the mechanical field, we do that as well. It's an amazing, surprising distribution. It's not something that you would expect. You would expect maybe 2 or 3 mechanisms to be dominant, so you have peaks with certain concentrations. Not the case. It's very homogeneous. Are we the only ones? No. I took 2 other images from literature, and there are surprising. I had to do some flipping to make the axes identical, so don't look at the axis, but you can see here that these distributions are very much like the ones that we've seen. So this seems to be a very consistent pattern. The oldest one, this one, I think, data from 15 years ago, this one from 5 years ago, and this one from last year, that over the time this seems to be a very consistent pattern for the intracranial thrombi. And here again, by the group from Stefan de Meijer, also some examples of histology confirming that these cross-sections are pretty heterogeneous. So, coming back to the heterogeneity, cross-sectional wise, like I said, there's quite a mix of components that you see in each cross-section, and also the way they are patterned is very different. Sometimes that halo I referred to before, this one is much less structured, and sometimes we see also like what we call a cow-like pattern, that there are islands of red blood cells encasted by fibrin tissue. So each cross-section is very different. From the previous one, we know that each the average composition is different. But if we look, if we take samples from an individual patient, and we look at the concentration of red blood cells, or the average concentration of red blood cells in each cross-section from that thrombus, from that patient, we can look at how this varies, and we can quantify this with the coefficient of variance. And then if we look at the red blood cell content within a thrombus coming from a single patient, If you go from proximal to distal or from the midsection, it can vary 60%. Many of the models that we use and many of the assumptions that we adhere to when we do designs of experiments all tell us, well, a thrombus has 60% red blood cells. No, it doesn't. There's a huge variation even within the thrombi. So this is pretty well quantified, and consistent data have been shown in intracranial thrombi. This is a very recent work from last week, no, 2 weeks ago, sorry, where we looked at, where we did the first histology of venous thrombi taken from patients, and if anything, they're more complex. Beverly referred to it yesterday. Maybe these fibrin layers here are related to the effect that you have been alluding to, that thrombus gets formed, red blood cells adhere to that, and then another fibrin layer gets formed. You also see some blue stuff. That's, in this case, other, and we don't really know what it is. But some of it seems to be smooth muscle cells are in there, at least. But we did not do any specific stainings for that, so I cannot give a definite answer here. But intuitively and from an engineering point of view, even more complex, and they just look older, more mature, right? So thrombus composition. Take-home message here. You can expect basically any average composition that you can imagine. And the chances that you get a certain one are equally distributed, which is rather surprising, which is still surprises me. The distribution that we find is very reproducible. So my message here is, don't do this again. It's a freaking lot of work to do this, and the data is out there. So if you need data, come to us, and we are happy to share them with you if possible. We even have additional slices from each location, so we could even potentially do additional staining if needed. Of course, the conclusions are obvious: high cross-sectional heterogeneity, high interpatient variability, and DVT thrombi even less studied and even more heterogeneous than the AAS thrombi. Okay, getting the patient data is difficult. You want to perform methodological studies on the relationship between microstructure and mechanical properties, and the best way to do that is try to generate these thrombi in the lab. Can we do this? Actually, if you accept that you first start with homogeneous thrombi, which it's not a bad thing because you can do good mechanical testing on these samples, then that task is not that difficult. You can very easily create whole blood thrombi just by taking the thrombi in citrated tubes, transfer them to another tube, add calcium and thrombin, and then within half hour you've got a thrombus. Of course, you want to play with the composition a bit, so that's what we did. So we separated first the cell content, the red blood cells from the blood. In the second step, we separated the platelets from the plasma, and that way we have three constituents that we can recombine. So we just have plasma, we can add an amount of red blood cells, we can add an amount of platelets just to play around with the composition. And of course, we can also do this without red blood cells, and then with platelets, which we call platelet-rich plasma, or without platelets to get platelet-poor plasma. And this is basically how it looks. If we want to do mechanical testing, then we have two options basically that everybody starts with. First is compression testing. You need cylindrical specimen, or you want to do tensile testing, and then you need this dog bone-shaped specimen. And then the cylindrical specimen, they are just generated by letting the blood coagulate inside a syringe. And for generating these tensile test specimen, we designed a few molds to make sure that we can generate these specimen. And the big trick here is that clamping these soft tissues is always very difficult. So what we do is we add a bit of Velcro inside the mold so that entangles with the specimen so that we can clamp it and pull on it. And this is how they look. From a histology point of view, you see some cutting out effects, but you can see that, yes, these thrombi are really very homogeneous. So from that perspective, they are very suitable for doing mechanical testing, because you test one sample of which you know the microstructure and the composition, and that's homogeneous, so that allows you to do all kinds of transformations of forces to stresses and displacements to strain. But of course, what we have to keep in mind is that they do not really represent the heterogeneous thrombi that we find in patients. So what happens if you make these thrombi? One of the surprises that we had is so this is the process that happens during the formation of the network during the coagulation. So on the horizontal axis is the amount of red blood cells that we start out with if we want to generate the thrombus. And on the vertical axis is the amount of red blood cells that we end up with in the thrombus in the end. So of course, if we don't add any red blood cells, then we don't see any red blood cells in the final sample. But if we add like 2% of red blood cells in the initial suspension, then the final concentration of red blood cells in the network is already almost 50%. Which means that during the process of forming the network, or forming that thrombus, basically that process is very efficient in capturing almost all red blood cells that you put in. And you can see that also because the fluid that is left over is nearly transparent. So during the process, all the red blood cells that you add are basically captured by that network. And it makes, if you go for red blood cell suspension with roughly the physiological hematocrit, and you follow the procedure that we follow in our lab, of course that's not something that happens in your body, then you almost already have 100% concentration of red blood cells in your final sample. That was, of course, our initial experiments, where we did not look into the detailed effect of platelets. Of course, that is something that is very important. So that was the next step in our experiments, to see how we can make these samples, where we made these samples with different concentrations of platelets, from 30 to 90 to 270, 10 to the power 3 platelets per microliter. Again, this is the substances as we start out with on the lower axis the red blood cell concentration. So here we've got that full range that I've shown you before, with low platelet concentration, with intermediate platelet concentration, high platelet concentration, and you can see the tremendous effect that these platelets have on the final volume of the samples that you generate. If we look at, for instance, the 2% here, the central one, with the low platelet concentration, the sample is almost completely filling the syringe still, while here it's gone tremendously small. And this quantity we just defined by the quantity contractility, and that's just a ratio of the volumes, initial volume here, with the volume of the final, with the final sample, and I'll use that quantity later on a few times. So this is just demonstrating the tremendous effect that platelets have on generating these thrombi in vitro. Of course, we also did a ramp, increasing the platelet concentration from 0 to 400. You see the largest effect is between, like, say, 0 and 150, and that levels off at 200 if we look at the vault contractility here, and that means that at some point adding more platelets does not make the thrombus any smaller. Okay? So that's the homogeneous part, so we can make them, we can play around with the content, we can play around with the contractility, so that gives us the tools to try to capture the relationship between microstructure and mechanical properties of these specimens. Of course, we also want to explore a bit how these heterogeneous thrombi can be made, and this device was mentioned yesterday as well, the Chandler loop, in which you basically create a flow regime in a closed circuit, and you can add platelet-rich plasma or blood, and at some point you will generate thrombi here as well, if you carefully add some calcium, and a little bit less of thrombin, because otherwise the process goes too quickly. And then you can generate thrombi like this. They can be pretty long, and this one here, especially in the central part here, you can also see that there's some heterogeneity in there, and these of course are platelet-rich, platelet-poor, I'm not sure. At least there are no red blood cells in here, but you can see that there is some heterogeneity in this thrombi. There's differences between the heads and tails in the central section, and this seems to be a very cool process, although it's pretty hard to control. So even if you're very careful, you can get different thrombi with different compositions under identical conditions, using identical protocols. Once you make them, you can take a look at them, and you can see that the speed of rotation of the device that we use definitely has an influence on the microstructure of the thrombus that we generate. So this seems to be also a good tool to play around with that aspect of the whole microstructural mechanical coupling. And you can also try to quantify that. In this case, we looked at the diameter, and you can see that in this case, the diameter of the fibers under steady conditions are much smaller than the ones that were generated under flow. And in a very small pilot study here, we did not see a strong impact on differences in rotational speed, so flow conditions on the diameter of the fibers. Still something, a pretty standard tool, not complicated, which allows you to play around with that, although controlling everything is a bit difficult. Take-home message from this part. Like I said, it's pretty straightforward to generate these homogeneous thrombi. It's the rapid network formation that makes it a bit more difficult to generate these red blood cell poor thrombi, but practice is a good thing. And of course, like I showed, the effect of platelets on the structure is really important. Heterogeneous thrombi, not many people try to address this issue. It's not very easy, no accepted protocol as yet, especially if you want to have mature thrombi. And like I said, it's hard to control, and maybe we should step away from trying to control everything very nicely, but embrace the variation and measure what you generated afterwards in trying to instead of trying to control everything on forehand. Questions so far?
Thank you very much for this first overview. But for the thrombus formation or thrombus creation, you're always using thrombin in addition, or I have probably skipped it?
We try to do it with. Yeah, we played around with thrombin concentration, also with and without thrombin. Yeah. We didn't explore the effect of having a fast or slower well, in the end, it turned out the main influence is how fast the process goes. Yeah. And we wanted to have it like a bit rapid, because that helps us to do experiments within one day. Yeah. Especially if we use blood from patients. Yes, of course, you can get them without thrombin. This is just a faster way of doing this.
Yeah. But if you have only 40% of red blood cells, and then in the thrombus you have in the end, you have, as you showed us, you have almost 100%. It's clotted, but there's no structure inside.
Yes, of course, that's the big disadvantage of having this this approach, that you create these homogeneous thrombi. And the good thing is that you can try to do reproducible experiments, sure. And that's difficult enough, as I will show you later.
Thank you.
Thank you very much. I have to say something horribly mean, but it needs to be said. The definition of a thrombus is a clot that forms in a vessel. So you're looking at clots. I'm terribly sorry.
Don't be. I was just a bit tardy here, because normally I use the word clot analogs for this. fully aware of the fact that these are different, to a certain extent, different beasts.
Thank you for the talk. Have you checked during the clot formation in the experiment? You said that the composition is very, or the structure of the clot is very difficult to control. Have you checked the time, the clotting time of these? Have you seen if these times are correlated to the structure also?
No. We just followed one protocol, and that means that the time that the clots gets formed are pretty narrow, but especially it's a very interesting question, and by playing around with the amount of thrombin in the medium, we can influence that clotting time, so we can surely explore that. So yeah, good point.
Hi, thanks for the talk. I was wondering if thrombectomy could significantly damage the thrombus that then you observe, and could it impact significantly your observations?
Yeah. Yeah, it's true. I mean, we try to peel it out of the retriever as carefully as possible, but it is always entangled by the retriever, so it has to penetrate the clot, so it is always damaged. Yeah.
Very nice presentation. Have you looked at VWF fibers in the thrombi?
No.
Do you plan to do it?
After the presentations of yesterday, I think I have to. Right. No, we did not yet, and nor did we look at calcium, which also might be an interesting component to look at.
Now, did you try to, because you have a huge heterogeneity in the thrombi, did you try to look whether there's a link to etiology, whether thrombi can come from the carotid if you have an ongoing thrombosis, or atrial fibrillation from the heart?
That will always remain a mystery from a fundamental point of view, because there's no way to establish where a thrombus is coming from objectively. We get a diagnosis, is it coming from the heart or not? And that's based on the fact that they have additional imaging of the heart, so if they see an enlarged atrium, and if the patients have atrial fibrillation, then they say the thrombus is coming from the heart. So it's a proxy, circumstantial evidence that these thrombi might come from the heart. It's so circumstantial, and we didn't even try to look at it now. We might have to do that at some point, but we didn't do any association between that diagnostics and the overall composition of the thrombus so far.
Okay, and do you think you can get information if the thrombus, when it arrives in a cerebral artery and blocks it, is still evolving?
Again, it's...
So the thrombus will come and block the cerebral artery. Is it evolving at this stage? Is it still growing? Do we have any information out of it? Is histology helping?
I can only assume that it is, right? I mean, it will be there. It's going to be exposed to blood on the proximal and distal side. I don't see any reason why it would not interact with the blood that is surrounding it. The problem always is that if you would want to prove that, you could prove that if you have histology, right, of an intact intracranial thrombus, they're not there.
Yes. Because
they have to do it 4 or 5 times, and even if you get out in one piece, then it's still not possible to... there's too much uncertainty to try to link that to either proximal or distal side.
And last question, you mentioned 10 retrievers. They work well, but they don't often get the complete thrombus out. Yeah. Can we make them more sticky? How would we do that?
I will come back to that later, maybe at the final part. Okay, I will continue. Because mechanical engineering, right? So we want to know something about the mechanical properties. That's what we all started about. The first and simplest experiment you can do is unconfined compression. You just put a sample between 2 horizontal plates. You push one plate down, and you measure the force, and then you can have force displacement curves, which you can then transfer into strain stress curves, which allows you to extract material properties from that sample. Here's a typical force displacement curve we get. In this case, we had a loading protocol of 20 consecutive cycles, all going to a strain of 80%, and this is what the displacement force curve looked like. Not very surprising. A peak, of course, at the maximum strain that decreases over consecutive cycles. And of course, this, if you zoom in here, you can see some other things, that this seems to be having a lower slope at the beginning of the compression, and there seems to be some asymmetry between the loading and unloading curve, indicating viscoelastic or poroelastic behavior of your specimen. I'm mentioning viscoelasticity and poroelasticity here. Interpreting these data is pretty difficult, we found out. So I'm going to stick to the analysis of the first loading curve, where we can potentially extract some meaningful data. So if you zoom in here, in this first part, you convert it to strain and stress values, then you can see that there's a very long toe here, toe region, where the material behaves linearly and is very soft. There's a nonlinear regime where we see observe strain stiffening. That's a common feature for all kinds of biological tissues, especially if you've got networks, that there is some nonlinear strain stiffening behavior. And at some point, it gets linear again with a much higher stiffness than in the original region. And this protocol we applied to a first initial data set that we got from 20 patients, where we generated these samples that we could subject to thrombectomy. And we are looking at the, in this case, I'm showing only the high strain stiffness, so that's this value here. And as a function of the composition that we got from these specimens. So these data, so it's from 19 patients, but we got 41 specimens here, 41 samples that we could measure from these patients. And on our horizontal axis here, we get the amount of fibrin and platelets from the H&E staining. And this is something that you would intuitively expect, right? If there's more fibrin or there are more platelets, then you expect a denser network, and you expect that network to be stiffer. Since they are almost complementary, of course, with the red blood cells concentration, then you can see the inverse. If you've got a sample with a lot of red blood cells, then you get softer behavior of these samples. So there seems to be a pretty intuitive logic relationship. But as things go with tissues that you extract from patients, yes, you can do regressions. Yes, you can find correlations. But look at the range of values that you get. So for a clot with red blood cell concentration of 10%, your values can range from 200 to 2,000. So that's 1 decade. That's a huge variation. We also made correlations with white blood cells. We didn't see that much. We looked at platelets, and that had a bit of a different relationships. Our epidemiologist told me I can do this kind of correlation. I think it looks ugly, but I think the conclusion is justified that at lower platelet concentration, there does not seem to be a big influence of the platelets here, and at a certain value, they seem to be contributing to the stiffening of the specimen quite significantly. So the overall composition, if you got lots of red blood cells, softer behavior, platelets seem to play a role as well, and the variation that we saw in this initial data from patients is huge. So that's why we want to move back to our clot analogs, right? And we want to do a bit more than just the compression test. So for the clot analogs, we also make these samples, like I showed you before, to do tensile testing, and we can generate curves like this, where we just start the experiment and increase our displacement here, denoted by time. We measure force, and at some point, the specimen fails. Why didn't we do that for the patient data? You cannot make tensile test specimen from in vivo thrombi. They're just too scattered. They're too small. They break all the time, and you cannot make these specimens. Something that was discussed yesterday, so I added this as a short, brief intermezzo, is you always assume here, if you do these experiments, that they are fully reproducible, you don't make any mistakes, and that you always get the same results if you follow the same protocol. Let's find out. Intermezzo. This was done in the context of a clinical trial I mentioned before, where we had to have 2 or 3 lab technicians to work together on testing the specimen, because, of course, these specimens come in during the day, and we said, like, we want to accept them for 18 hours, but we don't want to have a lab technician available for 18 hours, so we had to have more people, and you want those people to do the same, right? So we had a training protocol. Every week you do 1 set of experiments on fresh blood, just to practice and make sure that you're on the same page. That's what they did. So every week, at least once, sometimes twice, they generated samples for compression. Here they made 2 of them, so to be able to see how reproducible the compression is itself. So this is how it looks before, and this is how it looks after. And they also made 2 specimens for tension, 1 for cyclic straining and 1 for failure. This is what one lab technician did, and another lab technician did exactly the same. And they were working next to each other, following exactly the same protocol, and see what comes out of that. Of course, we can look at some basic numbers. So, for instance, the amount of contraction. Even there, you can see already that there is some difference between the 2 samples that one technician made. So the contraction is already a bit different. So the network structure seems to be already a bit different. The coefficient of variation here is roughly 4%. So you can make these samples, look at the cross-sectional area for the 2 syringes. We also did ultrasound cross-sectional measurements for the tensile specimens, so you can compare the overall geometry of the specimen that you get. And this is a typical number for the geometrical variation that you get, even following exactly the same protocol, working next to each other, so there's not a minute between generating one specimen and the other. Still, there's quite some variation to be found. And this is a selection of the results. This is stiffness, I think, again, the high strain stiffness. Yes, high strain stiffness for each sample, and then the average value for observer 1, observer 2. And fortunately, you can see that there is a quite strong correlation. But you can also see that there are, some of them are really very close, and some of them are a bit further apart. And let me point out this number here, the median intra specimen variation. So what one technician measures between the two samples that technician made is roughly 13% for the compression testing. And if you look at the inter-observer covariance, it's 17%. What does this tell you? I was not super happy with this, but there's also no way to change this. This is just what happens. So there is no variation. The machine is the same, the blood is the same, the equipment is the same. Just making and cutting the samples induces this kind of variation. If you look at the tensile stiffness, I thought that experiment would be much complexer and much more variation. But this one seems to be more reproducible, which kind of surprised me, where the median intra-observer coefficient is 9%. And this one, I don't know, there's one outlier which basically screws up this number. But on average, they are closer together. So take-home message here is, even under fully controlled circumstances, expect variations in the order of 10% with homogeneous samples, so let alone what happens with heterogeneous samples. Well, don't stop doing experiments, but be aware of this, right? Okay. So going back to the clot analog data, we discussed this one quite extensively. It's the compression test, where here I show you here the results for whole blood. Negative strain is the compression experiment. Positive strain is the extension experiment. The compression experiment you've seen before, but now it's flipped. So very soft linear behavior at low strain, nonlinear regime, and high stiffness at high strain. The tension is different. It's linear, which is kind of surprising for a network. And this is very consistent. It always has these features. So that was a big surprise, for which I don't have a very good explanation, to be honest. If we look at how these properties are influenced by composition, here again I look at the data from the thrombus clot analogs for different red blood cell concentrations, and you basically see a confirmation that we've seen before, that with the stiffness of the sample decreases both in the high and the low regime with increasing red blood cell concentrations, right? So like for the compression, we can also determine low strain stiffness and high strain stiffness for the extension experiments, and then we can take a look at these values here. Again, first as a function of the red blood cell concentration, these are the extension experiments, and this is for low red blood cell concentration, high red blood cell concentration, and you see a more or less linear decrease in the stiffness, confirming what we've seen before. We see the same results for the high strain stiffness, and what is remarkable here is that the axes are identical, which means that they have identical values, which means that they have a linear relationship, linear behavior. Still surprising. Different behavior we see at compression, where we can see that there is a difference between the low strain stiffness and the low strain stiffness at low concentration and high concentration. But look at the axis here. It's so much softer under compression than under tension. That's really amazing. And here we see something that is really a bit unexpected at the high strain stiffness for compression, where there is a significant increase going from 0 to 10% of red blood cells. We did some SEM imaging of these samples as well. And the one here with the 10% red blood cell concentrations, that seemed to be the concentration where the red blood cells that were encapsulated in the network had a slightly different shape. People refer that sometimes to the octahedral shape, I think, where they seem to be not circular, but having a slightly different shape with some angles. And that seems to happen at a certain porosity of the network. If we increase the density of the network, that feature disappears here. I'm fully aware that these images are not the best one, but believe me, this is what happened there. So maybe that's one of the explanations for this increase in stiffness here, that these red blood cells were forced into a different shape in the network. So, like I said before, platelets do play an important role, and we now can control these platelets, the amount of platelets in our samples, so we can tweak out that effect. And here again you can see a map of the red blood cell content for the low strain stiffness, high strain stiffness, and each observation is color-coded by the platelet content. So here we've got the 0% red blood cell samples, and the more orange it gets, the more platelets are in that sample. So if we look at the red blood cell concentrations for these samples, the impact of the red blood cell on the stiffness is less than for the patient data, and you can see that the platelets seem to be having a role in the stiffness values as well. If anything, if we look at the correlations for platelet content for the low strain and high strain stiffnesses, then you can see that that correlation between the amount of platelets and stiffness is much stronger than for the red blood cells. You can see here a cluster of samples with a high blood cell concentration, low stiffness, that makes sense. So here it's a bit whiter, a bit more fibrin-rich. But platelet concentration, and especially for the high strain stiffness, seems to be dominating the mechanical properties over the red blood cell concentration. So, take-home message for the patient data. There seems to be a rather intuitive correlation initially, right? More red blood cells softer, more platelets stiffer. The variation is enormous, and that might be induced by the interaction between the red blood cells and the platelets, because they have different impacts on the properties, and we did not quantify them separately in these patient data at that time. Thrombus analog data, yeah. Don't underestimate the effort it takes to generate protocols to perform good experiments and good people to do good experiments. But it's worthwhile to put effort in it, because that's where we get many important answers. The interplay between the red blood cell content, and I should add the fibrin network here, and platelets on how these clot analogs behave from a mechanical point of view is pretty intricate. It's not dominated by one of these features. They are all interconnected. Okay. Can we image these properties? Or can we image the composition? But of course, imaging composition is step one, but we would want to know what the properties are. Of course, if a patient gets into the clinic, they get a CT scan, we want to know from that CT scan what kind of clot is in there. Is it one that breaks up very easily? Is it one that's very firm? So that we can maybe select devices on forehand to optimize treatment there. So this is a set of experiments that we did on our first set of clot analogs that we made. So these are the clot analogs that we started out with a homogeneous red blood cell distribution, but ended up with samples that had almost no red blood cells or a lot of red blood cells. We put them in a vial, put them in a clinical CT scanner, and did imaging. And then we just measured the Hounsfield unit of that sample, which is something that you generally do with a patient as well. I'm not going to talk about this contrast enhanced. I'm just talking about the non-contrast enhanced CT scan here. This is the vial, and here you can see the thrombus. And if you look at the average density in the Hounsfield units, yes, you can see that there's quite a significant difference between the one that has no red blood cell and the one that has a lot of them. And that's something that is very significantly different. And we can understand, of course, because the red blood cell absorbs the X-ray radiation and therefore gives a higher signal. Like I said, I'm not going to talk about the contrast enhanced scans. So yes, apparently this is promising and expected. At least in these simple conditions, we seem to be able to discriminate between very low and very high red blood cell content thrombi. So very soft one and very stiff one. But again, these platelets, they keep on worrying us because, like expected, they do have an impact on the structure and therefore on the compaction, and therefore there could be a strong interplay between the imaging features of a loose thrombus with a lot of red blood cells and a very tightly packed thrombus with a small amount of red blood cells. So this is an example here, again, much like the previous images, where we can see here an increasing concentration of red blood cells of the initial solution, giving us these final results here. And yes, again, if you look at the red blood cell content as such, there seems to be an increase in the Hounsfield unit. And if we look at, again, like at the low concentration red blood cells, then we can still see these color coding for the platelets. So it's identical to the previous one. If we look at the density here, then we can see the functional dependency on the red blood cell content, where you can see a positive correlation here, again with quite a lot of variation, and that variation is linked to the amount of red blood cells, platelets, I'm sorry. So let's focus here on the ones with a very low red blood cell content. Here again, that same picture, and just look at these two squares. What we see here is a thrombus that has a very high red blood cell concentration, right? And a very low platelet concentration, which would make it a very soft thrombus, right? If we look at this square here, we've got a thrombus that can have basically any platelet concentration, which means it can have any stiffness. And if you look at the range of Hounsfield units that we see in these two boxes, they are identical, which is kind of a bummer, right? Because based on the Hounsfield unit alone, you can have different compositions, and these compositions will result in very different mechanical properties. So traditional CT imaging, following our protocol, doing the ex vivo, given all the limitations, of course, that are there, do not qualify to measure mechanical properties of thrombi. Is take-home message here. If you look at the composition, mechanical properties, and the extremes in these homogeneous clot analogs that can be imaged with some reliability, is there a link between conventional CT data composition and mechanical properties that we can use in the clinical setting? Don't think so. And I missed one image here, is it? Okay. Maybe I'll show that later if I've got time. There's a new technique, photo counting CT imaging. That might be more promising. I added that image. I thought, I hope that the other images that I added this morning are still in there. We can find better images of composition with this imaging technique, even in patients. And what about those patient data? Like I said, I showed you the histology previously of 66 patients. We also collected the imaging of these patients, and we are and did the mechanical testing of 270, 280 specimens, and we are currently analyzing these data. And hopefully we will not confirm what we saw in the analog experiments. So last block. That's about how to make a device to remove that efficiently. And these stent retrievers that are used in current practice, they are based on coronary stents. And these coronary stents are made to open a vessel. They are not made or designed to retrieve a thrombus. They got into clinical practice because they were approved for coronary application, and then getting approval for another application is much easier if you don't tweak around with the design too much. And that's what happened. And that's where we're stuck. We're still using that same suboptimal or stupid approach to try to remove the thrombi, because we have to go through the thrombus. We don't know where it goes through the thrombus. Then we have to push it against the wall. We don't know how much damage we do to the vessel wall during that process. It will break. Definitely it will break. So part of the thrombus will be shut down downstream. And then you have to get it back into the catheter. And you lose it. You lose part of that thrombus on the way. And you have to get back in, scraping the wall of the vessel and stuff like that. So this is not a very good approach. So we thought about various designs of trying to cut this down in several principles with this general concept. What if we grip the thrombus instead trying to poke through it, mesh it, and retract it, right? So let's see if we can grip it nicely and then just pull it back into the catheter. This is the general approach here. So we've got 3 arms. We've got 2 pairs of 3 arms. So one pair has a gripper here that is extending outward. And if you pull the green part back into these blue tubes, then it gets straight again, right? So it can in, out, in, out. This part is meant to gently push the vessel wall outwards. We've got a second set of 3, which is basically the inverse of this one. So they go inward, and there are interspace between these two, between the other ones. They go inward, so they go inward and go forward and they grab. They go forward and they grab. So we'll push the wall outward, we take the other set, comes forward, grabs the thrombus and pulls it backward. You don't have to go through it. This is how it looks like in reality. So it's still a bit big, but it has a size that's potentially usable for DVT. This is all driving stuff. It's a camshaft-driven system, and here you see the 3 grippers, the 2 set of 3 grippers, and this is a movie. So these are the ones that push the ball outwards. And while this is moving forward, pushing the ball, this one pulls back the. Oh, this is an earplug like that. Got it. Didn't break it. Didn't damage anything. Earplugs are, of course, not thrombi. So last week, actually, we did the final set of experiments. That's this here. So this would be a tube, silicon tube with stiffness comparable to an artery. Yeah, yes, boss. So this is a silicon tube here with properties that are comparable to an artery. This is a fibrin-rich thrombus, which we made in the lab. We stretched it a bit. Okay, great. So we stretched it a bit just to seal off, so to clamp the thrombus in the tube, like it gets lodged in an artery. We put the device on top of it, and here you can already see that while moving down, the grippers were able to pass the thrombus without pushing it forward, because we were a bit afraid that that would happen. And then if you start turning it the other way around, then it just captures the thrombus and pulls it out. It also works for for red blood cell rich thrombi. So take home message here, a fun thing. The concept seems to work, but lots of work that needs to be done. And that's it. Of course, the people I worked with in Delft, I especially want to thank Bruce Veredonijad for the design experiments, Paul Breedveld, and the master student Sasha. That's why I have to leave this afternoon, because she's going to graduate tomorrow. Erasmus Medical Center, the Biomechanics lab, lots of work was done by Rachel. Ottilia played a very important role. I see I forgot Janneke. Sorry for that, Janneke. And of course, nothing could be done without our excellent clinical team from neurology and radiology. Thank you for your attention.
Thank you.
Questions?
Thank you really much for this extremely interesting talk. I would like to ask you if the information about the tensile stiffness gives us an idea of the maximum force that we can apply in retrieving the thrombus. Which kind of information for the thrombectomy gives us the compression stiffness of the thrombus?
Let me start by saying that, of course, during the whole procedure, the thrombus is subjected to a very complex 3D loading environment containing all the mechanical loading components that you can think of, a tensile, shear, compression. So all of them are individually relevant. Using these simple experiments give us the opportunities at least to compare part of that mechanical behavior. But to fully understand what is going on in that thrombus, you need all of them, obviously. So you need to characterize the behavior in tension, compression, and we just designed a device that we can also do shearing experiments on these devices. I think the most important information that we are still missing is, and which will be hard to quantify, is how they fail. Because that's something, of course, that happens during these processes all the time. We penetrate them, we break them, and then they fail, and we have very limited data on how that process actually is going on.
I have two quick questions. Regarding the viscoelasticity, you think that could be important due to the fact that after the time relaxation, maybe we can have a strain that is higher than that one predicted to the elastic model, with the elastic.
My answer is yes, and even clinicians know that, because once they deploy the stent, they always wait. They don't know how long they have to wait, but they know it takes some time before the retriever is fully engaged with the thrombus, and that is of course a viscoelastic effect. So they apply that knowledge in clinical practice, but we just don't know exactly what's going on, because pore elasticity is also important, and that's why that range of waiting time is kind of arbitrary. So every hospital has his own waiting time.
Okay.
It will be important.
Okay.
Especially also if you look at processes like aspiration, where you just apply suction pressure and just have to pull down, retrieve the thrombus. Yeah.
And do you think that with this wonderful device that you showed us, do you think that could be possible to navigate inside the cardiovascular?
Absolutely not. No, but it's this. In this case, it's the working principle. I think the way forward with this device for now is trying to use it in much straighter arteries, and then going for deep vein thrombi. It's more advantage. It's straighter artery. It's not that risky, and you've got more time. So it's not applicable for cerebral environments, but more for venous environments. We started out with the principle. We built a prototype. I think the principle is still a valid one, even for intracranial applications. But there are the steps that have to be taken are much, much larger and much more numerous than for deep vein thrombus application.
Thanks. Thank you very much.
Thank you for a great talk. I have two questions. First one is regarding also on the mechanical testing part. Could you comment on the hysteresis as well as whether there are any aging effects that you see even in a purely physical context regarding these thrombi?
Good question. I cannot answer that at this point. I don't really regret it, but part of me regrets it nevertheless. We've adapted the protocol so that we could compare our findings against other preclinical studies that were done before. They subjected their samples to very high compressive strains. The effect of that high compressive strain is that you expel fluid, which is not surprising, from your sample. You can visually see that happens. Not all the fluid gets sucked back in to the sample, so you have a different structure in the end. So the hysteresis effect that we observe will always be a combination of a poroelastic effect and a viscoelastic effect. And teasing them apart, I think we need models to do so. Otherwise, we will be just juggling around with these numbers without knowing what to look at. So at this point, I cannot answer that question because we didn't do that yet.
I see. And then the second one is regarding the last video that you showed. How you also mentioned earlier about the shape of the actual thrombi is highly not ideal, you can't really use ideal geometry to model that. So I mean, in terms of the actual application, to make sure that even whatever the shape that your device is able to grip it, do you need to actually apply more compression force so that you can act on different uneven surfaces, or how do you approach that?
So for now, the approach is pretty simple in the sense that we just said, okay, we've got two extreme, from a mechanical point of view, two extreme examples of thrombi. One is a stiff rubbery-like, fully compacted fibrin-rich sample. The other one is a very loosely packed red blood cell-rich sample. And let's see if at least it can grip both of them with the gripping extension that we use now. So yes, fortunately, I did not expect we would succeed with the red blood cell sample. But this is something that you can imagine that if you bend these grippers, that is one thing that you can vary during your experiments, and then you can basically change the compressive forces that you act on your sample, and that might be one of, I think that's one of the first things that we would go for optimization there.
Okay, thank you for your presentation and the research. I'm Daniel. I'm neurointerventional radiologist, and from a clinical point of view, I think it's a field in which we are still advancing, even if the actual treatment is good for the patients. We still have some heart thrombus that we do not arrive to put out of the patient, and it will be very interesting to measure the thrombus characteristics inside of the patient, so yes, maybe with the microcatheter or the microguide wire, and also to evaluate depending on the thrombus characteristics and force, if we may change the thrombectomy, the mechanical thrombectomy we are doing now, to some other methods, as for example focused ultrasonography in the thrombus, depending on the thrombus characteristics. Yeah. So, well, it's a very interesting field, and thank you for your research.
Yeah, I think it's one of the things that obviously has great clinical attention, and also the combination of targeted contrast agents with ultrasound to gently destroy thrombi. That's also something that might be something that could be potentially useful if you get to these arteries that are too tortuous, where you cannot go in with a catheter, you damage the vessel wall. You have to find other ways if your thrombolysis approach doesn't work, and maybe these gently destructive procedures might be a way to go. Keith.
So we've been doing some modeling on, we've been doing our own clot analogs, and one of the things that we've sort of looked at recently is the effect of the vasculature gripping the clots, right? So there's a tension and compression effect because of the vessel itself, and also that it tapers, right? Yeah. And so what are your thoughts on how all that plays a role in what all of us are trying to do in terms of understanding how to extract these clots?
I think for intracranial application, the concept is, or at least the way I see it, is that the clot generally is not formed at the location where we find it, right? So you can more or less assume that the artery where it's lodged in is pretty okay, pretty healthy. So, and that's one. The second thing is, given the fact that symptoms are very close to the intervention, that there will be not a lot of time to form all kinds of, let's call them biological interaction between the thrombus and the vessel wall that are very strong. Combining these two observations, I think we can get a pretty long way, pretty far with modeling those aspects. So I think we can model the fact that it's squeezed by an artery, and we can model the fact that it's in a tapered environment. That, of course, does not hold for the venous thrombi, where the interaction, I anticipate that the interaction between the thrombus and the vessel wall is much stronger, and you've got these valves there, which makes it a much more difficult problem.
Yeah, so talking about the DVTs, we've done some animal studies where we've seen in a 7-day animal reorganization of the clot and the endothelium actually infiltrating into the clot itself. Wow. And so now the clot is completely changing in terms of its properties and cellular distribution. Yeah,
that's what we saw on a very limited number of histology samples that we did. There are some things that seem to be pretty similar, but there are also things that are hugely different, I think. Yeah.
Hi, thanks for the presentation. I'm coming back to this poroelastic effect that you already mentioned. So when you apply a stress, right, you see this strain stiffening, and if I got it correctly, you think that this might due to a change in the porosity of the structure?
Yes, I think so, yeah.
And then the related question is, could you think of a way of measuring this permeability of the structure? Or have you tried?
Yes, I can think of various ways to do so, and they all seem pretty straightforward, but I also know that some very talented experimentalists try to do this, and it is much more difficult than you would anticipate to do these experiments. One thing that we are going to try, especially with the photon counting CT scanner, is to just follow under different compressions the permeability of the structure for contrast agents, for clinical contrast agents, under a slight pressure gradient. So that's what we are going to do. It's still a very simple approach. I don't know if it gives us the answer. You would expect it is, but it's much more complex than it seems to be.
Just to come back to this curve that you showed, and that was intriguing. So the increase of the Young modulus, or the modulus of your material with the volume fraction of red blood cells.
Yeah.
So if I think, or you help me think about that, I guess. So if I think about the composite material, the simplest one, which are cavities in the homogeneous material, if I remember well, if you pull in such type of material, the Young modulus will decrease depending on the volume fraction of cavities.
Correct.
Now, if I replace the cavities with droplets that have a surface tension, then it's the reverse that happens. And there is a recent paper that showed that these HLB theories are modified, and then you get an increase of the. So could it be that now, if I think about the red blood cells that are not droplets, but that have a membrane, that their mechanical stress could maybe be modified during this event? What I'm seeing here is that type of process, at least for the low volume fraction regime.
Okay, that's interesting. I didn't think about that.
I guess
it might well be. I mean, I think I don't know these theories that well, but I think there's also like an optimum that this increase with the droplet goes to a certain concentration, and then that effect disappears. So it might be it's at least an indication that it's worthwhile to think about it. It's to be honest, I'm not such a fan of that theory of the differences in the shape of the red blood cells, because I just don't understand why that would necessarily lead to stiffening, actually. So I don't see how this more or less continuous behavior would spring from that observation. But it's the only real observations that we have that makes this point around the 10% different from the other points. So that's why I brought it up. But I don't have a very solid explanation for it.
Okay, thank you for the very nice talk. So the Young modulus is part of the story, even for the simplest mechanical behavior.
Yeah.
The other part, one of the other part, could be the Poisson coefficient.
Yeah.
Have you looked at that?
Also, with a bit of regret, I have to say we didn't. We could have measured it, obviously, and I think it's something that we're definitely going to do, especially if you also are more interested in the poroelastic behavior. Then we have to characterize the whole volume, and we can do that, and then we immediately have the information of the Poisson ratio as well. No, we did not.
Thanks.
I was wondering if the thrombus had isotropic properties, or if it was maybe affected by flow direction or growth direction.
We did not directly measure that, so the only answer I can give is based on the structure that we see. If we look at the clot analogs that are made under static conditions, they will be homogeneous. And they will be isotropic because there's no preferred direction. The ones that we make on the flow have a definite orientation, preferred orientation of the fibrin network in the direction of the flow. And that's also what comes out of all these microfluidic experiments. Yes, there's a pretty strong connection there. So based on all we know, these will definitely behave anisotropically. The thrombi in the patients obviously do not have that clear of a preference of orientations as the ones that are made in microfluidics channels. And the orientation that they have is also most of the time a bit heterogeneously distributed over the sample. So most probably yes, there will be some level of anisotropy in the thrombus, but that will, like with all the things that we measure, show pretty broad distribution.
I have a question about the first part, the characterization of the composition in space. Mm-hmm. Can you translate that into time information in some way? I mean, for example, at different locations, do they correspond to different ages of the thrombus? Is it something? Do you think the composition evolves in time?
I think it will, and I think it does, but I cannot answer that based on clinical data that we have now. The problem is that our clinicians that treat the patients, they cannot see the thrombus. So they don't exactly know where they are with their devices. So even if it would come out in one piece, or you grab a part of the thrombus, you don't know if it's the distal part or the proximal part that you're taking out. And if you take it out, we always show the nice samples where we've got like a thrombus that is like 1.5 centimeters in one piece. If you go to the theater, then you've got pieces of 1 millimeter, another, and you've got 12 pieces that are taken out of the patient. So there's no way that with any reliability you can reconstruct which part came from what part of the thrombus. The clinician seems to agree.
Okay, and from the knowledge of the spatial variations, could you say something also about the spatial variation of what you could measure at the CT scan, for example? Because I think in the CT you showed only results for the average.
Yeah.
But what about the spatial structure? Can you see it?
So the conventional CT that we're using now, we are doing, like I said, we're doing the analysis in this new patient data set. There we tried to indicate 5 locations along the thrombus where we measure the Hounsfield unit. The problem is it's pretty difficult, especially if you use non-contrast enhanced CT, to determine where the proximal and distal end of the thrombus is. So that was quite an effort to do that. I've got the hopes that with the photon counting CT scanner that has a resolution that is at least a factor of 2 better and provides much more contrast, that we can make steps there. But clinical CT data now going for heterogeneity in the thrombus, they're small, man. They're small.
Okay, thanks. No, last question? No? So then we're gonna thank Frank again. Thank you.